Next. Okay, so today we're going through the endocrine system. So the endocrine system, when it comes to the GPHC exam, is it low, medium, or high weighting? Does everyone know? Absolutely, high weighting. What does high weighting actually mean? What percentage of the assessment will high weighting material make up? No, higher than that, Julia. So it surprises a lot of people. 60 to 70% of the assessment is made up of high weighting material. That's very important when it comes to your studies. So what proportion of your studies should be focusing on high weighting material? 60 to 70%. It should be the amount of time you spend understanding and being confident on a particular topic should correlate with how much of the assessment it actually makes up. Sounds like common sense. I see people do different to that. So often I lose count. So make sure you know your high weighting topics the best, which topics, which therapeutic areas fall under high weighting material. Cardiovascular system, absolutely. Central nervous system, respiratory is medium weighting, infection, and endocrine system. So the four are the cardiovascular system, endocrine system, infection, and the central nervous system. Okay, so what's the aim of today's session? I want to introduce you to diabetes mellitus. Of course, from your undergraduate studies, you should be very confident and have a good understanding of diabetes mellitus. If it's a bit rusty, absolutely no problem, but it tends to be one of those topics people find easier to pick up compared to others. How do people find insulin? What about insulin? Do you find that difficult to understand? Can be quite confusing. Yeah, it can be quite confusing. So for those of you who don't know, I've been a type 1 diabetic since 2001. So that gives me a bit of an advantage. I've also taught diabetes to undergraduate students as well. So I've taught diabetes to undergraduate students, and I manage patients with diabetic foot infections in clinic. I'll give you a brief overview of my role and my background for those of you who don't know. So I currently work as a senior lecturer in pharmacy practice. So I teach pharmacy undergraduate students. I also work for the postgraduate diploma. I work for marking for the antimicrobial resistance module. So I support with that. I'm also, half my week, I work as an advanced specialist pharmacist. Currently, I work in the department where I manage patients with interstitial lung disease. I have a strong background in antimicrobials and infectious diseases. So I worked as an antimicrobial pharmacist and also an infectious disease pharmacist for 4 years. So where does my background come for the endocrine system? Well, I've taught over 600 students that are undergraduates diabetes when it comes to university level. I've also taught for the endocrine system for 3 years via MicroPharm. So it's one of my strong areas. So let me introduce you to diabetes mellitus. So diabetes mellitus is a group of metabolic disorders in which you've got persistent hyperglycemia caused by deficiency in insulin secretion or resistance to the action of insulin. So diabetes, you've obviously got the possibility of 2 types. What's the main difference between the 2 types of diabetes? Type 1 and type 2. In terms of the most common classifications, what are the main differences? Yes, Julia. For type 1 diabetes, your body doesn't make any insulin. My body doesn't make any insulin at all. I'll just move myself to the side. For type 2 diabetes, the patient can produce insulin, They can sometimes produce less, or they have problems with the receptors on their cells not recognizing the insulin that's there. So this leads, of course, it leads to abnormalities in carbohydrates, fat, and protein metabolism. If you consider sugars that are released from your foods in your blood, insulin is the key. It's the key to your cells that allow the carbohydrates and the sugars to be absorbed into those cells. So it's extremely important to have either the sufficient amount of insulin being produced and also for the insulin to be recognized appropriately, because this determines your blood glucose levels. And of course, if you have abnormalities with that, patients with diabetes mellitus have a higher blood glucose level. The two most common classifications of diabetes are type 1 and type 2. Other types of diabetes are secondary diabetes. So what do I mean by secondary diabetes? Anytime you see the term in medical terminology where you see the term secondary diabetes, it means it's happening as a result of something else. So an example of that is acute pancreatitis can lead to secondary diabetes. Why do you think that occurs? What do you think is happening there? Yeah, so the pancreas makes the insulin, absolutely. So acute pancreatitis is inflammation, so damage to the pancreas. And therefore, if you've got acute pancreatitis, you can damage the islets of Langerhans, which produce the insulin in the pancreas. You've got gestational diabetes, which of course happens during pregnancy. What can happen with gestational diabetes is often patients with gestational diabetes are tested following the delivery of the baby to see if they still have symptoms of diabetes. In most cases, this should resolve following on from them giving birth. All drivers who are treated with insulin must inform the DVLA. So when I say all drivers, that are treated with insulin, am I relating this to patients with type 1 diabetes only, or type 1 and type 2 diabetes? Both, absolutely. Because there's a risk of them being treated with insulin of what? What's the risk if someone's having insulin constantly? Risk of hypoglycemia. So hypoglycemia being your low blood glucose levels, there's a risk of this. There's essentially a risk of this if patients are being treated with insulin. If drivers are being treated with insulin, they should carry a blood glucose meter or blood glucose strips, or they could use the continuous glucose monitor, and they should check their blood glucose readings no more than 2 hours before driving and every 2 hours when driving. What should a patient's blood glucose levels be before they drive? When would you say it's safe for you to drive? At least 5 millimoles per liter. Absolutely. So the aim when you're treating someone with type 1 diabetes, so focusing on type 1 diabetes, is to use an insulin regimen that achieves optimal control of a patient's blood glucose readings. Ideally, you want the HbA1c concentration to be 48 millimoles per mole, and if you're using the old units, that's 6.5% or lower is recommended in patients with type 1 diabetes. They should be monitored, so readings of your blood glucose reading should be monitored at least 4 times a day, including before each meal and before bed. Quite a lot of type 1 diabetics and all that type 1 diabetics are actually recommended to have a continuous glucose monitor now. And the continuous glucose monitor allows them to have readings every 5 minutes. So it's drastically changed. The way we manage diabetes has drastically changed. So why is it important? Why is it particularly important before testing your blood glucose readings before each meal and before bed? Why before each meal? So let's start with that. Why is that important? Yep. So you give yourself the right amount of insulin. So if your blood glucose level is higher than it should be, then you need to give insulin to reduce that. And then you have to take into account the insulin that you're going to inject for the carbohydrates in a meal. So it's very important to have an understanding of where you are before you give your injection, because that determines how much injection you actually give. And when I'm saying this, I'm referring to the basal bolus regimen, which I'll go through in later slides, which is the gold standard when it comes to managing type 1 diabetes treatment. In terms of aims, so in terms of before bed, think of that entire window whilst you're asleep. You want your blood glucose levels to be in control. So that's why it's extremely important to check your glucose readings before bed. So in terms of targets, if you're fasting, you want a target between 5 to 7 millimoles per liter. If it's before meals, you want it between 4 to 7 millimoles per liter. If it's 90 minutes after eating, it's between 5 to 9 millimoles per liter. There's an increased leeway after eating because your body is now absorbing the carbohydrates and the insulin is kicking in. When it comes to fasting on waking, the threshold, the target is slightly higher. And that's because you don't want people going for a target of 4 whilst they're sleeping. You have the risk of something called a nocturnal hypoglycemia. All that means is having a hypoglycemic event during your sleep. There is a risk of death if patients have hypoglycemia in their sleep and it's not treated. So it's extremely important to ensure people aren't floating at lower levels or going for lower targets whilst they're sleeping. And like we said before driving, at least 5 millimoles per liter. So in terms of insulin therapy, the gold standard is a basal bolus insulin regimen. What is a basal bolus insulin regimen? Yeah, that's a great question. Once people answer this question, Saweed, I'll answer your question. Yep, your basal is your background insulin. Your bolus is your mealtime insulin. What are you trying to do here? You're trying to mimic what the body's actually doing. Your body produces, a healthy body without diabetes mellitus will produce a small amount of background insulin when you're not eating and will produce mealtime insulin when you are eating. So we'd ask the question, how do you calculate how much to give based on your meals? Are there apps? So there are several apps when it comes to things like this. The most important thing is there's a comprehensive course provided by the NHS, which is called the Daphne course, which means dose adjustment for normal eating. But the basis behind the Daphne course is you look at how many grams of carbohydrates there are in a meal, and you determine how many units you need per 10 grams of carbohydrates. Now, there's no blanket rule for that. And the reason why there's no blanket rule is for every 10 grams of carbohydrate I eat, I give myself 1 unit of FIASP insulin, and we'll go through the different types of insulin. But sometimes some patients have a 2-to-1 ratio. And what that means is for every 10 grams of carbohydrates they eat, they need 2 units of insulin. And that changes for different types of bodies. And you have to take into account the amount of body fat a patient has. You have to take into account patients' metabolism. What you tend to find is it's difficult. You tend to find patients that are underweight requiring less insulin for their meals, but it changes from patient to patient. So we spoke about basal bolus regimens. We also have mixed biphasic insulin regimens. What are mixed biphasic insulin regimens? Short acting, they tend to be a mixture of two different types of insulin, correct? It tends to be short acting and intermediate acting together. And that's why often mixed biphasic insulins, as the name suggests, it's given twice daily. So that's it's given twice daily. So the biphasic should lead you on to thinking there's some intermediate acting insulin involved, because intermediate acting insulin is given twice daily. And it has a combination. It has a proportion of short-acting insulin, which is your mealtime insulin, and it also has your intermediate-acting insulin, which is your background insulin. When do you think you advise patients to take these injections? What do you say about meals? With food, as the short acting is included, absolutely. So a common mistake a patient can make, particularly when they're newly diagnosed, is not taking it with food. The short acting side will act very quickly, relatively to the intermediate acting side. So its onset of action is about 15 to 30 minutes. It'll be about, it's dependent on the type of insulin that's in the mix. So onset of action will be about 5 to 15 minutes. If it's rapid acting insulin, it can be 30 to 60 minutes when it's a short acting insulin. And then you have a continuous subcutaneous insulin infusion, which is an insulin pump. So when we're talking about insulin pumps, how many types of insulins are included in an insulin pump? Yes, Julia, one. How do you think that insulin is given? Bolus when eating, yes. So it's a combination. There's a bolus, you can bolus when eating. So you tell your pump how much insulin to give when you're going to eat. And also you have your background, which is you can determine your background. So you give a small amount of rapid acting insulin every hour. So mine will be like, let's look at how much insulin I'm receiving this hour whilst I'm speaking to you. My basal is I'm receiving 0.5 units of rapid acting insulin this particular hour. So between 9 and 8 p.m. And that differs from patient to patient. The beauty of your insulin pump is you can change how much insulin you require depending on which time of the day it is. Patients with type 1 diabetes should be offered multiple daily injections, so a basal bolus regimen as a first-line choice. Why is that important? Yes, better control is the premise behind that. What do you mean by better control? Can you expand on that, Julia? Yeah, more similar to how the body works, but we have to talk about something extremely important. What's the main disadvantage of a mixed biphasic insulin regimen? What do you think? So I went through how a mixed biphasic regimen works. What do you think the main problem is with that regimen? Possibly, there's a risk of high, but if a patient's having it with mealtime insulin, it's no different to a basal bolus. Not because of how quickly the short acting works, because you're in a basal bolus, your rapid acting works faster. We're assuming something huge about all patients here. What are we assuming? Not everyone is the same. And also, what else? It's someone's put it in the private chat. We eat. Have you had a day where you well, maybe you've had 2 days where you've ate exactly the same amount of carbohydrates, but how often are we going to eat the same amount of carbs every day? The fact that we're making a sweeping statement that sweeping statement and assumption that patients have the same amount of carbohydrates every day is, to me, it's ridiculous. And that's exactly what we're doing with patients that's exactly what we're doing with patients that have a biphasic insulin regimen. We're assuming they have the same amount of carbs every day because you're giving them exactly the same amount of short-acting insulin every day. And that's where the terrible control comes in with a biphasic insulin regimen. The beauty of a basal bolus is your background, your basal will stay the same. Your bolus, your mealtime insulin, you change it for the amount of carbs that you're actually having in that meal. So patients with type 1 diabetes should be offered a basal bolus. The first line is twice daily insulin detamir. Why do we say twice daily insulin detamir rather than once daily? What type of insulin is insulin detamir? It's a long-acting insulin. How often do we give long-acting insulins? How many times a day? We've got one person's directly messaged me to say it's at night. One person has said once daily. So generally once a day. Why are we saying twice daily for insulin detamir? And that's in the BNF. So you will see that in the BNF. So isn't that sort of counterintuitive, counterproductive? What do we think? I think these are important points to consider so you can actually remember them for the assessment. Does anyone hazard a guess? More more extreme rise in glucose? Possibly. What does this relate to? Yes, so we're getting there. So if you're considering the duration of action for the insulin, so insulin definitely has a lower duration of action compared to other long-acting insulins. After 20 hours, its effects start to taper off. So we'll look at that on a graph. And because of that, you want better coverage by splitting the dose. You've also got better flexibility with giving patients a higher dose at a certain at night, for example, and a lower dose when they take their morning insulin. And that gives you some level of flexibility. If they can't have that, then you can give once daily insulin glargine. And if they can't have once daily insulin glargine, then you can give once daily detamir. So twice daily detamir, your first line. What's the brand name for detamir? Levemir, absolutely, yep. And the name should help you with that. What about insulin glargine? What's the brand name for insulin glargine? Lantus is your most common example. There are other brands on the market now, like Semglee. Also, leading onto my next question, how many times a day for Lantus? If you are recommending it to a patient. Once daily, absolutely. It's once daily. And then if they can't have that, then it's once daily of insulin detamir. So Mrs. Williams takes Nova Rapid for her mealtime insulin. She is due to eat breakfast. When should she take her insulin for breakfast? Okay, I've got one person to say 10 minutes before, one person saying 30 minutes before, and one person saying directly before she eats. Okay, let's put a poll. Just bear with me. So A for directly before she eats, B for 10 minutes before, C for 30 minutes before. So what I'm going to do soon, we're going to go through the next few slides and then we'll end this session here because I've got another session coming up later on in the month where we're going to go through, where I want to go through insulins more comprehensively. So I think that would be a good idea because I really I underestimated how long it would take just to go through the introduction. And I'm just halfway through my slides for today. So what I'll do is we'll go through some more of these questions to understand types of insulin, and then we'll have a dedicated webinar for insulin that I will make free for all users. Okay, so got a bit of we've got half of you saying directly before she eats, half of you saying 30 minutes before. What do we think about 30 minutes before? What's the risk of 30 minutes before? What type of insulin is Nova Rapid? It's rapid acting. Is there a difference between rapid acting and short acting? The BNF, by the way, will tell you these. The BNF can tend to confuse you because they all fall under short acting. Yes. So you've got two different types that if you want to categorically simplify short acting insulins, you've got soluble insulin and then you've got rapid acting insulin. Well, what's the difference between soluble insulin and rapid acting insulin? Rapid is faster than short acting insulin. Absolutely. So every time you see the term soluble insulin, that's where that's referring to short acting insulin. And soluble insulin is relatively slower in terms of onset of action, in terms of its peak onset of action. It has a longer duration of action as well. So when it comes to Mrs. Williams, ideally you say directly before your breakfast is absolutely fine because of the fact that it's a rapid acting insulin. Onset of action is relatively quick, 5 to 10 minutes. It already has an onset of action. Its peak is about 1 hour, but it starts to work after 5 to 10 minutes. So in terms of rapid acting insulins, you've got a few different types. You've got Humalog, which is Lispro, Nova Rapid, which is Aspart, Apidra, which is glulisine, and Fiasp, which is Aspart. What is the difference between Fiasp and Nova Rapid when they both contain insulin aspart? Fiasp has a faster onset of action, absolutely. Um, does anyone know why? Faster absorption, faster onset of action, absolutely. So in terms of manufacturers, they're the same. There's an addition of vitamin B3, and this addition of vitamin B3 is what gives it a relatively quicker onset of action. This can be between like 5 to 10 minutes, but 5 to 10 minutes when it comes to you having several meals during the day is a big deal. I'm on Fiasp insulin, and there is there is a noticeable difference between the two. I'm snacking so often. Those 5 to 10 minutes of a quicker onset of action mean a lot to me. In terms of onset of action, it's within 15 minutes generally for considering all of them. In terms of peak, 1 to 2 hours. Duration of action, 2 to 5 hours. It's injected immediately before meals. There used to be a routine where people used to say to have your rapid-acting insulin after your meal is absolutely fine to patients. We completely avoid that now. So the routine use of this is completely avoided. We advise patients to have it before their meals, not after. What's the problem of a patient having it after their meals? Um, let's say they don't forget. There's still actually a problem there. Yes, what tends to happen because your peak is 1 to 2 hours, a patient's sugar level will start to go high fairly quickly, particularly if it's a carb-heavy meal. And then the risk of that, the risk of a patient's sugar levels going higher, and then you giving insulin after a meal means you just give an unnecessary 1 hour delay. So that's why it's very important to have the rapid acting insulin before meals. We are going to finish off with this last case. And then the next webinar, I'm just looking at the dates for our schedule. The next webinar where we go through all the more insulins in more detail will be on the 23rd of October. I put that up on the micropharm.org website, so you can sign up to that session. So you can sign up to that session after today. So Zara takes Humulin S for mealtime insulin. When she's due to eat lunch, when should she take her insulin for lunch? Oh, interesting, Julia. She shouldn't take it. Oh, she shouldn't take it before lunch, or oh, sorry. I was confused. So this is where the normal practice is 15 to 30 minutes before food. And that's because Humulin S is a soluble insulin. So it's a short-acting insulin, it's a soluble insulin. What are some of the challenges for soluble insulins? No, so really, when someone said take them often in the day compared to long acting, what are some of the challenges when you compare a soluble insulin to, for example, a rapid acting insulin? Yes, you essentially have to plan to take your insulin 30 minutes before your food comes, which, if you consider how we eat now and expecting Uber Eats deliveries, Deliveroo deliveries, it sounds like a nightmare to me. And you will probably always either get it wrong, or you'll end up resorting to just taking it directly before your meal. And the risk of taking it directly before your meal is your peak after your meal. So your postprandial peak will be higher. So you rather be on a rapid acting insulin. it just makes logistically more sense. So this is where we will stop today's session. I'm going to put a poll function just for your feedback for today, just to see if you found today's webinar useful. And then I will see you on our next webinar is the end of this month, where we'll be going through a quiz style question, going through GPHC style questions. If you want to be up to date with regards to the advancements with the new membership, head over to www.micropharm.org and you can sign up to the webinar. You can sign up to the newsletter, sorry, and then you'll be in the know. If you want to sign up to the pro membership this week, before Saturday, before the price goes up, then you can do so on micropharm.uk. That's good to see that everyone found it useful. So thank you everyone for attending. Those that are MicroPharm members, I will upload this recording to your platform right now. So once we're end this session, I'll download the recording and pop it onto the online platform. Thank you everyone for attending, and I will see you in the next one.